Let's talk about management of SLE in pregnancy. So I'll talk about the preconditions of pregnancy, the counseling measures, specific treatment, monitoring parameters, and what to do in delivery. So what are the preconditions of becoming pregnant if someone is an SLE patient? So the patient should have remission of the SLE disease for at least 6 months. And the remission should be done with a steroid dose less than 20 milligrams with or without azathioprine. That is the precondition. Remission for 6 months with a steroid dose less than 20 milligrams. But the counseling. So the counseling has two aspects. We have to talk about the impact of SLE on pregnancy and the impact of pregnancy on SLE. So first, impact of SLE on pregnancy. The impact can be on the mother or on the fetus. The mother can develop preeclampsia and hypertension, and there is an increased risk of abortion. And the baby can have low growth, so IUG or intrauterine growth restriction, IUD, intrauterine fetal death, and the baby can also be premature. And if the mother is anti-Rho positive, there is an increased risk of lupus in the baby or neonatal lupus, leading to heart block. What are the impact of pregnancy on SLE? The impact is increased activity of the disease, so flare up of SLE, and increased risk of renal failure. And how to monitor the patient? The monitoring parameters are the clinical monitoring and the laboratory monitoring. The lab monitoring includes the classic CBC, ESR, renal function test, including the UTP, creatinine, electrolytes, DSD antibody, anti-Rho and La antibody, and antiphospholipid antibodies. And how to treat the patient? So first of all, give folic acid from the beginning of the planning of conceptions, 5 milligram folate every day. Continue hydroxychloroquine, which is 6 to 6.5 milligram per kg per day throughout the pregnancy. Give low dose aspirin in all patients. And if the patient has positive APL antibodies, we have to give low molecular weight heparin. If the patient has a flare of the disease during pregnancy, we have to give pulse methylprednisolone. And obviously, if the patient has a Rho antibody positive, we have to monitor the fetal heart rate from 20 weeks onwards. What's about delivery? The delivery usually should be done in the hospital. And if the patient has anti-Rho antibody, we have to do ECG and echo of the child to check for the heart blocks and any other cardiac abnormalities.